Welcome, everyone. Happy Halloween, and welcome to the FLaNET community, and thank you so much for joining us. My name is Mintallah Haider. I'm a medical oncologist at Moffitt Cancer Center. We welcome your questions throughout our discussion today. It's a focused topic about imaging for the patient with neuroendocrine tumor, and I'm joined by my colleague, Dr. Brian Morse, who is an integral part of our team. And the purpose of our discussion today is to learn first about a very important physician team member in our multidisciplinary care that our patients don't meet as often as they do their medical oncologist. But our radiology teams are part of every patient's care and part of our tumor board. So today we hope that you can learn what their role is, and also to learn about particular imaging studies that we use in understanding neuroendocrine tumors for each particular patient. So Dr. Morse, welcome. Thank you for sharing your screen, and I'll hand it off to you.
Yeah, great. Thank you. Thank you very much for the opportunity. I really appreciate it, and I'm looking forward to today's talk. And just to outline the slides that I've prepared, I was given, some topics, things that come up frequently, that patients ask about frequently, or things that are a little confusing, maybe in clinic, that come up. And so have a list of those, and I added one or two things for myself. I'd mentioned if you want to, as a moderator, want me to expound on anything during that time or any questions that pop up, feel free to have me address those at that time. And we'll start. Hopefully I don't talk too fast. I tend to do that when I have a lot of ground to cover, but you can tell me to slow down too. The first thing I wanted to point out was a website, radiologyinfo.org. That's what you would type into your browser. And, there's a lot of information. When you're looking for information on the internet, it can be difficult, right? Because there's so much out there that's just not helpful or not accurate. And this was put together by two radiology professional organizations, the Radiological Society of North America and the American College of Radiology. It's a really extensive, I remember they started this years ago, and now it is really extensive. Has a wealth of information that is vetted, backed up by evidence and expert opinion. So, and it's a great resource. And if there's a topic here that I don't cover enough today and you want to learn about it, or if you have other questions, I'd highly recommend this website. One thing I would say, their drop-down menus you may not find what you want. And so if there's something you're looking for, you don't see it in the drop-down, just search for those terms. And I mean, sometimes I have more success when I'm trying to looking something up here or referring someone here, just searching for that term rather than using their drop-downs. And this would be an example of some of their content that would be interesting to your, a neuroendocrine tumor patient. So an explanation of an abdominal and pelvic CT scan. And they have this for all different imaging modalities, and it goes through, answers all these questions. So, what is it? What are their common uses? How would I get ready? What are the risks and benefits, et cetera? So it's a really great resource. The first topic that I wanted to touch on was just talking a little bit about the people in the people in healthcare that have radiology or radiation in their names, so you can kind of keep everyone straight, because it does get confusing. I tell my kids and family members and people I meet, they say, "What do you do? You're a radiologist." I say, "I'm a radiologist." Say, "Oh, you do the CT scans or you do the X-rays." I'm like, "No, that's not me." So the person that you actually see that will take you from the waiting room to the X-ray machine or the CT scanner or the MRI is called a radiologic technologist, and they also have various little specialty areas that they practice in. So there's CT technologists, MRI technologists for all these little areas, and there's a couple of different pathways to achieve that degree and get into this job field, and it tends to be as you get the more senior things like a master's degree, then those people tend to do more senior administrative or leadership roles in those areas. But the person that you actually see, for the person that you see and does the CT scan would be the CT technologist. I'm the radiologist, so I'm the person that you don't see involved with that process. So once those images are acquired, they're digitized and put on a computer network. And so it's not uncommon now that the physical location you get the scan, the radiologist who looks at that scan and creates the radiology report may not even be in the same building. and even at Moffitt now we have multiple locations around the Tampa area and even spreading outside there. And so, and the radiologist and the radiologic technology obviously will work very closely together and very important, both necessary 100% to do a good job. So you could have the best radiologist in the world, and if the radiology technologist does a bad job, you're not going to have a good outcome, and vice versa. If you got the best images in the world made by the best technologist, you don't have a radiologist who doesn't have the experience or education to do a good job, things don't turn out as well. So very important to the imaging team, both of us. And what the radiologist does, of course, we talked about, looks at the images, makes the report, and we're going to talk about that in a little more detail. But other things would be quality control of the imaging modality. So, you know, there are standards that have to be met by various accrediting organizations and internal standards that we set. Daily troubleshooting of things that come up, you know, issues with, whether it's issues with scheduling or, you know, patients having a reaction to a contrast agent, et cetera. Consulting with clinicians, and that's the radiology term for other doctors. So, and it kind of goes back to the day, you know, doctors see patients in clinic and radiologists don't, and so it's kind of a blanket term for a non-radiologist, but a radiologist would say be clinician. But working with people, and so like, you know, I'll talk essentially every day to people in the neuroendocrine service, whether that's, you know, Dr. Haider, Strasberg. Oh, I'm getting a little echo there. Okay. Talking with or the other advanced practice professionals they work with. So kind of informal conversations and then formalized conversations in tumor boards, professional service on hospital committees, professional committees. And then there are some things we actually do see the radiologist. So we will do biopsies, image-guided biopsies, using typically ultrasound or CT. And then there's something called fluoroscopy, where we actually look, an X-ray beam is working in real time. That's typically to look at like the esophagus or stomach or bowel. We'll have you swallow something that goes through your bowel that we can see with the X-rays. Not as common anymore. It's kind of been replaced by CT and MRI. But when that happens, the radiologist is there in the room with you. And those are things that all radiologists do, regardless of their practice setting. The last two of research projects and teaching of you know, medical residents, radiology residents, and fellows, and other healthcare providers or medical students. Those are things that are kind of more confined to somebody like me who works in an academic type setting, you know, at a health science center or a cancer center. That's not as much for someone who's in private practice, but those are the different things that the radiologist does. And to get there, it takes a while. So it's, you know, the pathway is pretty similar for all doctors. For radiologists, there's 5 to 6 years of radiology specific training at the end of that. And so just to bring up quickly too, then it gets a little confusing because there's other doctors who would have radiology or radiologists in their name. So there's interventional radiologists who essentially do a very similar training, except their fellowship years are spent in what's called interventional radiology. And that's a lot of biopsies. So, you know, radiologists do biopsy, but an interventional radiologist may do the more complicated or high risk biopsies. And then they're the only ones who put catheters, small tubes inside veins and arteries to actually do therapies that way. And so for a neuroendocrine tumor patient, what you might encounter them when they're doing a biopsy, or then probably more often even if you had to have what we call liver-directed therapy, where medicines or things that stop blood flow or radioactive particles are introduced directly into the liver through the arteries to treat tumor in the liver. So radiation oncologist then is similar. So radiologists use small amounts of radiation to make diagnoses, to find out what the problem is. A radiation oncologist uses much, much larger doses of radiation to actually kill tumors. And their training path is similar. They do a residency in radiation oncology. It's not as common to do a fellowship, then they're certainly very familiar with imaging because they use that to guide their therapies. And so they're the ones who are actually using radiation in different forms to treat tumors. So just to cover a little
Dr.
terminology
Morse?
there, yeah.
Sorry to interrupt, but if we can go back to the slide, one more back, I wanted to highlight two things that bullet number 3, consulting with clinicians. I call you almost on a daily basis from clinic, and I think what this highlights is you're able to put the findings on a scan into the patient's specific story and answer the questions that we're seeking from the scan. So for example, if I added a CT scan for someone in pain, we get on the phone together so I can explain what I'm finding on physical exam and labs and the particular questions I have, and you're able to put that into perspective when you're reading the scan. Is that what you were hinting at there?
Yeah. I mean, you'd be, the volume of imaging is so high nowadays that all radiologists and the people who are ordering the scans just have a hard time keeping up with things. But one of the nice things about working here at Moffitt is that you kind of build these close relationships with people that are not as common. If I'm in private practice reading somewhere, I'm reading scans from all over the city, possibly all over the area. I don't really know who I'm working with. And like you said, here, since we all kind of work together closely and it's a smaller center, I get, phone calls every day, and whether that's about outside imaging or giving me some extra history or, a lot of times, particularly when the cases can get really complex, right? When you get rare tumor types, or rare even for Moffitt, or when therapies stop working and you've got to move on to less well-established therapies, things start to get really complicated. And so it can be hard to convey things in the report, or there may be specific questions about the report about the imaging that you can't, I don't know about when I'm reading the scan. And that's a problem with radiology that is, we kind of address here because, we just text each other, call each other, to get that kind of back and forth. It's an advantage, I think, of a cancer center in general, just probably the smaller volume and the closer working relationships. I think everybody would like to have that. It's just some places it's not as feasible. But yeah, those are the kind of things. There's all kinds of. I've never had a phone call probably from another doctor or a nurse or whatever about some kind of scan where it didn't help me make the diagnosis. Even though sometimes it can be hard when you're getting 10 or 15 phone calls because you still have to complete your work. But yeah, it's probably my opinion, it's probably one of the most valuable things that radiologists can do. And it's nice we have a place where we can do it in a kind of more feasibly manner.
Yes, and I wanted to bring that up because that's one of the reasons why we try our best to have imaging done wherever the patient is being treated. So keep that in mind as a patient or as a caregiver when you're planning care and where to get scans. There is an advantage of having it done where you are receiving care because there's that connection within the team as well. And keep in mind the second to last bullet point for research. So that's also another important point. We do a lot of scans on clinical trials, and our radiology colleagues are part of that research team, and they read these studies specific to the trial. And thank you. I wanted to highlight those 2 points. We can move forward.
Yeah, absolutely. So this is the first topic that was brought up to me as something that would be helpful to address, and that's for if you're a patient reading your radiology report. And I'm going to talk about this, but it's part of the list, so maybe not as in-depth as some people might like. And if you want more information, this is where I'd recommend radiologyinfo.org. So you can see here, this is their intro web page for how to read the report. They have a wealth of information there, and like I said, it's been highly vetted to be kind of an appropriate language that everyone can understand, but still accurate. And this is actually an example. This is from their web page that I'm going to use here, just to describe whatever kind of what we call in radiology different imaging modalities. So when I say different modalities, that's what we have: X-rays, ultrasound, CT scans, MRIs. They're all considered different modalities of imaging. And so, regardless of what type of scan or what the modality is, this is generally going to be how your report is structured. So the list of type of the exam, and it's supposed to be, so that if someone, opened that report, and now it's all electronic, but if you opened it, there would be enough information to tell what you're looking at. So there's probably going to be a name, maybe a medical record number for that institution, and then the type of exam. So oh, okay, this is Mr. Jones' CT scan of the chest, and it was done on this day. So there's some of these things are for, and we won't get into why these sections are there, because there's things about billing for exams, regulatory requirements, et cetera, why some of these things are there. So this is in general what you're going to see. So type of exam, there's going to be some kind of a listed reason or history for the exam. So whoever, just like a doctor or healthcare provider has to order a medicine for you or order a medical device, they have to order an imaging test. And so when they're ordering that, they have to, write a reason like abdominal pain or, a tumor staging or something. And there's going to be a section where the radiologists will list prior studies that they compared to, or they may list that in other sections of the report. There's going to be a technique section that kind of describes what was done. Not as helpful for the patient. That's really more of like one of these administrative billing type things. The meat of the report then is what we call the findings and impressions. So findings are basically a textual description of what's in the scan. And so for this example, it's an abdomen pelvis CT scan. And nowadays, pretty much everybody breaks it up into a list format like this. And they describe the different structures they see and if there's anything that are present and if there's anything unique about them. And you can see here, gallbladder surgically absent, spleen unremarkable or normal, liver, probable hepatic steatosis, which means fatty infiltration of liver. So the findings are basically what you're seeing. And the impression then is supposed to be a summation of important information in the report. And it should be just structured to address the reason for the exam or the history that was provided. So let's say, history is right lower quadrant abdominal pain. And then in the findings, you would say, in the findings there'd be, the appendix is enlarged. There's fat stranding around the appendix and fluid around the appendix. And then the impression would be acute appendicitis. So you can see the findings is what you're seeing, a bunch of list of things, and then the impression is typically more succinct or brief to kind of summarize the important points. And, now there's been legislation about patients having access to their test results and imaging as part of that. And, institutions are required to provide electronic access. And some things I would point out is that, the big problem with that with radiology reports is that it is definitely your imaging, right? It's your body being imaged, and you may have had to pay for that. If you didn't pay for it directly, you paid for it through, your health insurance that you pay for. So it's definitely something that you have a right to know about and see the final work product. I've had family members who've had imaging done, and they've had a hard time getting a hold of the results, and I found it frustrating. So, something you should definitely be available to you. But the target audience then of that report, though, is the doctor or the nurse, the advanced practice professional, healthcare provider who ordered it. And there's a lot of the vocabulary is different than how we speak. It's more formalized language. It uses a lot of medical terms, and sometimes there's even jargon. Different specialties of physicians have terms or acronyms that they use that, if I was in a room full of cardiologists and they were talking, I would know what they're talking about, but there'd probably be a couple terms or devices that they discussed that I wouldn't know because I don't spend a lot of time in cardiology. I do gastrointestinal, genitourinary stuff. So even doctors sometimes other doctors' jargon can be hard to understand. If we go to the report, it says there's probable hepatic steatosis. Well, that's not something you hear every day, right? So, instead of liver, we say, hepatic. So that's already a little awkward. And steatosis refers to, fat deposition in the liver. So it's fatty infiltration of the liver. And so it's not that the terms are being used to hide things or to be obtuse. It's just that's the language that's used. And when you're in healthcare, you learn that large vocabulary that you have to learn to use these more formalized scientific language. And it's confusing when you're a patient reading these things sometimes. It can be frustrating. I think, I'm dubious or cautious about the use of artificial intelligence tools in healthcare. I think they need to be highly, highly, highly vetted before we start using them. And, I think probably we're already starting to use them a little too quickly. But I do see this as an area for that could be of great benefit because, you think about things like those large language modeling, natural language processing. So we've all heard of ChatGPT. And so what you could do is take the radiology report and you could run it through one of these large language models and translate that into language that's more easily understood by someone who's not a doctor or works in healthcare. The trick is doing that accurately, right? Still conveying it accurately, but changing the language so it's more easily understood by an audience that's doesn't have a degree in biology or in healthcare. So it's something that people are trying to address in an area for future improvement. And then something else I would say, and this, I feel about this personally, the radiology report, and as a radiologist, you kind of tell you what's wrong. But the treatment then comes from your doctor. So to put it in the cancer setting, I look at the scan, I say, is there not cancer? How advanced is the cancer? But there's no answers beyond that on that radiology report. That doesn't come until you're in with the oncologist. They can tell you, okay, here's what the scan showed, and now here's what we want to do about it. Because me personally, I don't want to know what's wrong unless I can know what you're going to do about it. And so, if I thought about this, making this talk, if I had a scan and it was going to tell me if I had cancer, when would I access those results? Because they're probably going to be available before my doctor's appointment. And I was like, I would probably look at it before my appointment, but I don't, like, if my appointment was on Friday, I don't think I'd look at those results on Monday. And then I'd probably look at it beforehand, so I had some time to think about it and process it and come up with better questions than if I just went in and heard the results without knowing beforehand. But that's different for everybody. And I think sometimes it causes problems, or it's a problem, if you do run into that situation where say you're a patient who's been on cancer monitoring for a long time and you're kind of expecting your scan to be negative and it's a Monday and your appointment's on Friday, you get your CT scan over the weekend or something, and you look and see, and all of a sudden they've changed from the past couple of years, there's cancer there now, that's going to be a big shock, and you've got to wait all week to go in. So it's an individual decision, and I think about that before you are confronted with those results. And that's, we'll kind of move on because we could probably spend a really long time talking about that, but radiology.
I do have a question for you, Dr. Morse. Well, first, I think that's a great point. And it's, the days that we have our scans can be anxiety days, because even if, things have been stable, there's always, a sense of stress until we have the results. So thank you for pointing out when, to take that into consideration. Now, when you were talking about terminology and you showed us an example of a report, can you spend, just a minute telling me your perspective of the terms that sometimes are confusing when I'm reviewing a report with a patient? So sometimes we state something as a lesion, and it's perceived as then that means it's benign because another area was called a tumor. So can you briefly explain some of the terms you use for abnormal findings when you're following a cancer status?
Right. Yeah. And part of this is what I call that medical jargon. Say I'm reading a scan for small bowel neuroendocrine tumor. It's a patient who has known liver metastases, and there's no change. Then I might even say something in my impression like, no change of liver lesions and nothing new concerning. So, that term is kind of, unfortunately, that's kind of a garbage term, and kind of the medical jargon or lingo, that, because if you're, and that's what, because I know that, you're reading the scan, you're like, oh, liver lesions are stable. You're like, okay. What that means, right? But a layperson could say that lesions, there was tumor. So that's part of the difficulty in the way we talk to each other, and then someone, reading that and getting confused by that language. I can tell you the way I do it, but the problem is that, even at Moffitt, there's going to be 30 different radiologists reading scans, and some of the language used can be a little imprecise or abbreviated like that. So yeah, that could be, I think those difficulties can be particularly sometimes in the findings. Radiologists, when they're describing things, are not quite as precise in their language as they are in the impression. And part of that is just because, I may use abbreviations or terms that are vague, but they're not vague to you, or anyone who's involved with healthcare, any a nurse practitioner who works in your clinic, or but then someone else, a patient who's reading the report, is going to think that that's odd. And then, it's part of that's the human element of these scans, right? Is that the radiologists are different people, and some of these things are not well defined. There's not a, if I say, oh, there's a lesion in the kidney, that's a non-specific term. Like it could be a cyst, which basically means nothing, or it could be, a tumor. So we try to be precise about our language, but sometimes, particularly in those times when we've had 5 scans and there's been no change, and this is scan number 6 and there's no change again, then you might kind of think, oh, okay, everything looks fine. And you might relax a little bit in how you lose your language, and then you could lead some confusion like that. And like I said, it's not confusion among the healthcare team. Everybody's on the same team there, and that's part of the problem, is that we're structuring these reports for our target audience, which is my target audience is oncologists and all the people who work with them. And so we kind of develop our own language, and then when someone comes in outside of that, it can get confusing. So yeah, I can't tell you how any radiologist is going to use the term lesion, because it's probably interchangeable from scan to scan. And sometimes I've seen, I try to be precise, but people, it's just the variability of things. Say a patient has benign cysts in the liver, and then I've seen somebody refer to benign cysts as masses. Oh, there's multiple masses. Probably benign. Whereas most people would say a mass is something solid, but they think, oh no, it's just cysts. I'm sorry, I didn't mean to say. So there is a little variability in there, and it's just part of the problem. And that's why I think, that's why I like the workflow that I kind of think works the best from my experience over the years is, the report is produced for the healthcare team digests it, and then that translation process that I talked about takes place from the healthcare team to the patient. And then, sometimes there'll be some kind of specific issue that they'll ask about, and then you can address that, or if it's still weird, then you touch base with us, and then we address it. The advantages with you guys is you do that within minutes of it happening, right? Sometimes people have to wait when they don't know their radiologist that well, or where there's a little disconnect between where the imaging was acquired. Like, for example, if you get a CT scan you were looking at it from the patient's coming from, somewhere else in Florida with a CT scan, you have a question, you can't ask that person that question, because you can't just call them up right there and ask them about it. So there may be a little disconnect right there to get those questions answered. Probably, less so when the imaging is all acquired, say, here at Moffitt, and the appointment is here at Moffitt, but it does happen sometimes, yeah.
Well, yes, thank you. So I think, the big point here is that different words can be used to convey information, and we absolutely want everyone to access their results and reports, but actually going over it in clinic or with your physician is really what puts it into perspective. And so to not make decisions or really interpret it on your own, because there's a lot of variability there that needs to be recommunicated. Thank you.
Yeah, absolutely. The next topic was about what we call multi-phase CT studies. So I think there was some questions about why is it that we do what's called multi-phase, or sometimes people call it 3-phase or 4-phase scanning. Different terms can be used. Why is that used for neuroendocrine tumor imaging? And so, when we think about some of the more routine reasons for getting a CT scan, like you were in a car accident or you're having abdominal pain, you go to the emergency room. That kind of scan would just be, you'd probably get it, we would get IV contrast, and it would just be one time going through the CT tube, the CT scanner. And the timing would be what we call portal venous phase. And we'll get that in a second, explain that a little more. But in neuroendocrine tumor imaging, we use multi-phase imaging. What that means is that multiple passes through the CT scanner. And usually that's only through the abdomen, although sometimes it may be the abdomen and pelvis. And the timing of those images, and what I mean by that is, you've got an IV in. If before the contrast is injected, that's what we call a non-contrast scan, because you've got no contrast in your body. Then the contrast is injected. It goes in the vein, goes up to your heart, through the lungs, and it's treated all throughout your body through the arteries. And then eventually, it opacifies, or it gets into the arteries and veins, and it makes things enhance or makes them brighter. And we'll have an example of that here in a second. But so the timing of when that happens it kind of describes what there's features of those different phases or timing of imaging after contrast injection. So the arterial phase, and these are variable. Arterial phase could be maybe 20, 30 seconds approximately. Portal venous phase is more 60 to 90 seconds approximately. The arterial phase shows the arteries very well, so that would be important for if you're planning surgery or you're doing some kind of workup for peripheral vascular disease or something. And allows you to detect and characterize lesions in solid organs. And see, I use the term lesions here because we're talking about things that are not normal, and they may be benign or they may be malignant. And I have to slap myself on the wrist here, because then sometimes I use the term lesions to describe something malignant. So, but probably the best usage, if you say lesions, it's nonspecific. By definition, it just would mean something benign or malignant in cancer imaging. But portal venous phase then is kind of used because that provides the best all-around enhancement for all the structures of the abdomen and pelvis. And so that's why we use it for what we would call routine imaging. So just you're in the emergency room, fever, car wreck, that would be the timing. And the reason we use this is because for neuroendocrine tumor imaging, it provides the best assessment of hepatic metastatic disease. So we're talking about the liver. Regardless of the location of the neuroendocrine tumor, the liver is going to be one of the most common sites of metastatic disease. And the enhancement of those metastases can be very variable. They're typically what we call hypervascular, meaning they enhance the most in the arterial phase, but in reality, they can be quite heterogeneous. And we'll move on to some examples here, because that probably explains it the best. So here we see an example of a non-contrast CT scan. And so you can see it's a little harder to make out the details of the various structures that we see here. But then sometimes we can see tumors very well on non-contrast imaging, and sometimes you'll even make measurements on non-contrast imaging when the arterial phase or the portal venous phase is not working quite as well. These four images here are all from the same patient. This is a metastatic disease in the liver from a small bowel neuroendocrine tumor. And these are same day, same scan, but at different levels, head to toe levels. So one is a little higher than the other. And we can see here on arterial, the liver background is not quite as bright, but you can see there's multiple lesions in the liver. And so that's very typical of neuroendocrine tumor metastases. You see them best in the arterial phase. And if we go to a portal venous phase, you can see, wow, I kind of get an idea about the biggest lesion, but these other ones, I don't even see them. And same thing at this level. So multiple lesions, portal venous phase, you can see other ones, you may not even notice them. And that's the problem that's probably one of the problems we run into with neuroendocrine tumor imaging, is that when patients get imaged at places that aren't cancer centers or don't deal with neuroendocrine tumors a lot, they just do the portal venous, they just do standard imaging. And it's a problem, right? Because you can see there's lesions all over the place, liver tumors all over the place that we're not seeing. In the worst case scenario, you could look at it and think there's no evidence of metastatic disease in the liver, when in fact there could, there's many lesions, many metastases. So that's why it's important to do more. And then this is an example of why the multi-phase is important. So, not just getting arterial phase, but sometimes you see things the best in the portal venous phase. So here, this is the same patient at a different time point. You can see there's a little tumor right here. We see it pretty well, okay, in both phases, but definitely better in the arterial phase. But then there's another one over here where we hardly have an idea that it's even there on the arterial phase. So the neuroendocrine tumor metastases are very heterogeneous. They don't follow the rules that we like to think of. And anywhere up to 20% of metastases in studies have been found to show their best enhancement not on arterial phase. And so that's why basically we do these multi-phase exams. It's the standard for neuroendocrine tumor imaging to figure out what's going on in the liver. Now, if you say you've got a pulmonary neuroendocrine tumor and no metastatic disease in the abdomen or pelvis, and you're just getting chest CTs for follow-up, that wouldn't be like a multi-phase exam then. Or maybe if there's something in the pelvis, typically maybe not multi-phase through the pelvis, but for the abdomen, yeah. And that's what, we will do, that'll happen here, where we will get the scan for the abdomen, maybe multi-phase, and then through the pelvis, single phase, or sometimes there's tumor in the pelvis as well. We want to see multi-phase everywhere, but that's why the multi-phase imaging is used, and that's definitely not the standard. Like if you had colon cancer, or some of these other tumor types, that's not going to be the standard. Now maybe for detailed surgical planning for colon cancer would be, but for some of these other like say lung cancer, melanoma, these are not typically more common cancers, but they're not multi-phase imaging. For neuroendocrine tumor, that's why we use that. And kind of touching on that then is a little bit discussion about CT versus MRI and MRI contrast agents. So this is an example. This is a scan acquired outside of Moffitt, and it's hard to tell that there's anything in the liver. The timing's a little late. It's a little suboptimal. This may have been in an ER setting, not necessarily for like in a cancer clinic setting. We reacquired the scan here at Moffitt, and on there we're getting the suggestion that there's something wrong in the liver. There could be some metastases here. That's portal venous phase. This is the arterial phase, but still not getting a great idea. And so this patient went on to an MRI, and you can see here lots of disease, cancer in the liver. And we certainly were not getting that idea on many of these scans. And so this would be a huge change for this patient. And, CT definitely works well on neuroendocrine tumor and just cancer imaging in general. It's definitely adequate most of the time. But neuroendocrine tumors are a very heterogeneous group of tumors. And so there are some patients that we don't see their tumors very well with MRI, or sometimes even more commonly after different types of therapy. We have a hard time telling what's going on by CT, and so we'll get an MRI, or there's a quote unquote lesion that we can't tell if it's benign or malignant, and MRI can sometimes help you, give you extra information. And so it's not used all the time, but it's a very powerful tool when we need to use it. And some patients, they're followed routinely with MRIs just because their CT scans end up looking like this, no matter how you do them, and we just don't get a good idea what's going on. And this image from this MRI right here, it was specifically, the question was about EVIST contrast. And so, there's many. It's not worth your time learning all the trade names of the different CT scanners and contrast agents and everything, et cetera. There's all kinds of different manufacturers and everything. But EVIST is the trade name of a type of MRI contrast, and it comes up because we use it frequently in neuroendocrine tumor imaging. And it's what's called a liver-specific contrast agent. Now, it's not the only one, but it's the one that's most commonly used in America. And what it does is, unlike other contrast agents that they enhance while they're in the body and they're quickly kind of excreted from your body, it's a liver-specific contrast agent, meaning once it's injected, when that contrast gets to the liver, it's actually taken up. The liver cells actually grab onto the molecule and transport it into the liver cell and into the bile ducts. And so what that means is that the liver, after about 20 minutes after you inject it, the liver gets extremely bright. And so everything that looks bright is normal liver. But when you have tumor in the liver, it doesn't do that. So then these tumors stand out as being dark. And so the EVIST contrast lets us find metastases in the liver. It has multiple uses, but for cancer imaging, it lets us find really, really small metastases that we might have a hard time finding otherwise. It can also help us characterize lesions, because there are some benign lesions like focal nodular hyperplasia, which is kind of disorganized liver cells, but they're normal. It will actually look like liver on here and not like a metastasis. So it can help us characterize things too. And just to touch a little bit more on that, so this is from a paper actually that we wrote at Moffitt, talking about how EVIST contrast is useful for imaging neuroendocrine tumor metastases in the liver. And it shows typically you can see metastases in the liver very well by MRI. But the advantage of EVIS then, we see it on all these phases, and here are some post-contrast images. The lesions are seen, but then the EVIS gives you these really crisp images where there's very high contrast between the metastasis and the adjacent liver. These are examples of non-liver specific contrast agents, and then the EVIS. And this paper, and specifically what we talked about, was that it shows the highest contrast, meaning the highest difference for detection. Oops, my mouse is malfunctioning. For detection between the lesion and normal liver, and then for measurements over time. You can see how, if you definitely see this lesion very easily, so you're not going to miss it. MRI is still extremely sensitive when it's done without EVIS. One of the main advantages of the EVIS is when we're following lesions over time, and we want to see if the lesions are growing or getting smaller. What we showed in that paper and what other people describe is that you can see those things. You can see them and measure them very, 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 very precisely from scan to scan. So it's not mandatory, but definitely preferred for neuroendocrine tumor imaging, and we certainly prefer it. Everyone prefers it here at Moffitt, and so that's why when you're a neuroendocrine tumor patient, you're probably going to be getting the EVIS contrast. There are times where that may not happen. But most of the time it would be the EVIS contrast. And so that was a question, why are the MRIs done with EVIS? And other places that are not cancer centers that are not going to use EVIS as commonly. It's probably that its best indication is for cancer imaging. So if you're at some place that doesn't do as much cancer imaging, it can be a little harder to use for some technical reasons we won't get into. So they're not going to use as much as we use here at Moffitt. Next topic was asking about RECIST, some questions about what it is and why we use it or why we don't use it sometimes. And so RECIST is an acronym that stands for Response Evaluation Criteria in Solid Tumors. And these are basically guidelines or a set of rules and recommendations for how to conduct imaging in clinical trials. They were first published in 2000 and then revised in 2009. And when you think about if you're trying to create a new drug, a new chemotherapy agent, particularly if you're trying to replace a standard of care, a drug that already has been used for a long time and works very well, and we know about all the potential toxicity or problems you can have with that, you've got a big hill to climb. You're going to have to provide some really strong evidence to say, hey, my drug works better, and hopefully it's safer too. And so, you think I've got, okay, so we've got, a patient with cancer. I'm going to give them my chemotherapy agent, and then we're going to do scans before and after, and we're going to see if it works better. And say, okay, well, and not only are you going to do that at one place, to get the number of patients you need, you're going to do it in multiple states all across the country, and maybe even multiple countries all across the world. And so, you've got, how are you going to measure the tumor? Like, what are you going to measure on the CT scan? Are you going to measure one thing or 10 things? And how are you going to measure it? Or what kind of, are you going to use CT or MRI, and what's involved with that? And then what's a response? Like, what is things getting better? Like, the lesions are all gone, or one lesion's gone, or 10, so you can see how, if I'm in, you got somebody in California and somebody in, all across the country in Florida, and they say, oh, I gave the chemotherapy agent and they got a lot better. What does that mean? Right? You can't, it was a problem basically to do these trials. And so RECIST was developed as a way to standardize the imaging response. And so what do you measure? RECIST spelled out specific guidelines for what would be considered target and non-target lesions. And then how do you measure it? So there are different standards for imaging modalities, when they should be used, how they should be used. There's criteria for the measurements, very detailed criteria about how you add up the measurements, how you address the various things, like what if somebody misses a time point, or what if one study is done without contrast and one isn't. So very, very granular ideas about the criteria for these measurements. And then most importantly, probably is standardized definitions of what is a partial response, what is a complete response, and what is progression, meaning that the tumor gets worse. So it's basically a very detailed set of rules to eliminate all that heterogeneity and all those questions. And so you can compare data between different sites, and then you can compare data more legitimately between different trials. And so it sounds great, And one of the questions was, why don't we use it all the time? And it is great for doing research, but shortly after it was invented, there multiple problems were found, and they did the updated guideline, about 9 years after the first one. And, specifically for neuroendocrine tumor, say you're a patient, you have neuroendocrine tumor metastatic to liver, and the upfront therapies don't work for you. The disease is getting worse in your liver. And so they may send you to an interventional radiologist who then puts a catheter in the arteries to the liver and gives medicine to kill the tumor. And many times that medicine, or maybe it's just little beads that block the blood flow to the tumor. And so there's no blood flow to the tumor, or the tumor is dead, and so it's not enhancing anymore. It doesn't have that hypervascular appearance. And maybe when we image, all that enhancement is gone, but the size hasn't changed that much. That can happen, particularly depending on the time interval you get it. And so by RECIST, the response would be 0. Size hasn't changed, response is 0. In reality, it's a complete response. The tumor is completely dead. So you can see that pretty big difference in outcome right there. And this happens in RECIST trials. And so there's been multiple modifications to RECIST. People get very frustrated because they think their patient's getting better, but by the RECIST criteria, it's not reflecting that. There's been multiple papers published, particularly within the past 5 years or so, showing that if you pick the wrong lesions to measure, it can result in different outcomes. I wrote a paper with some of my other colleagues here at Moffitt about what they call non-target lesions, and how the selection of non-target lesions and their response, how their response is categorized, is very problematic. It leads to a lot of miscategorizations of treatment response. So, and it doesn't work well, I think, for neuroendocrine tumors. It's not uncommon then that the tumor in the liver will be stable, and then maybe just 1 or 2 lesions in the liver start growing. And so the neuroendocrine team will say, hey, everything looks stable, but we've got these 1 or 2 that are actually growing. We're going to go ahead and go after those and treat those individually and stay on the same other therapy. But if you were using RECIST, that would not be allowed, because just 1 tumor growing by RECIST is not a change. So it doesn't work for for day-to-day imaging. So using RECIST all the time, there'd be a revolt, basically, because there are a lot of issues. But it does work well for clinical trials. I mean, it works well for clinical trials, and some of that terminology, I think, has entered clinical care. So, RECIST says a 20% increase in tumor burden for progression, and that's kind of almost worked its way into the vernacular of imaging outside of clinical trials when people talk about progression a little bit. So, but so if you're on a trial, you're going to see these measurements, and the language is going to be a little different than a normal scan, because you can say things in a report that then can get picked up on and utilized inappropriately. So sometimes those scans are a little more vague in their impression. It may just refer to the target and non-target lesions. So that's another problem, is that the language can be very formalized, and if you use it inappropriately, sometimes that can result in problems. So to sum up, it works well for clinical trials, but you don't want to use it in day-to-day. That would be horrible. The next topic was talking about, if all the scans and CTs and MRIs are so good, then why do we still need biopsies? Or why do we still need to do like endoscopy to find things, or surgery to diagnose things? And, to sum up, basically, imaging is awesome. It's great. But there are benign and malignant lesions or processes. Those, you say, hey, I have a mass here in the liver. And sometimes, what we know is a malignant liver mass, or whether it's a metastasis or a primary tumor of the liver, and then something benign, like just like a cavernous hemangioma, or like I said, focal nodular hyperplasia, some of these other lesions that don't grow and don't go to other parts of the body, the imaging features can overlap. So you may think, well, we're pretty sure this is malignant, but we're not 100% sure. Or we're pretty sure this is benign, but not 100%. And to get that 100% proof, many times it does require a biopsy still. Now, not always. I mean, certainly that depends on this exact circumstance. And that's why, that kind of, like we said, the imaging goes to the doctor, and the doctor kind of puts together the whole picture of what's going on. And it's up to that physician then to say, well, I think even though this is not 100% of the imaging, it's almost 100% based on this clinical circumstances. So we're going to go without a biopsy, or we need a biopsy. And now, with so much of medicine and oncology in particular becoming so molecularly driven, addressing specific mutations with specific agents, we can't get that kind of granularity out of a scan. So, you may need that biopsy to look for specific mutations or grade specific features of the tumor. Even if you're like, oh, I know this is a metastasis, well, you're still going to biopsy it because you need to get that tissue to run those specific tests. Imaging can't do that. And it's probably going to be a long time before we can approach that level of granularity, if ever. Small size can also still be a problem. When you think about small bowel neuroendocrine tumors, we can optimize CT scans to look at the bowel and find extremely small lesions, but any neuroendocrine tumor surgeon is not concerned about that, because standard of care for neuroendocrine tumor surgery is they get their fingers on every centimeter of that bowel, and that's how they find, because they'll find, we may look at imaging and say that there's, say in reality, there's 20 small lesions in the bowel that are neuroendocrine tumors. By imaging, if we identify 15 of them, that's great. When you do surgery, you don't want to get 15, you want to get all 20. And so achieving that 100% accuracy it's just not feasible for how small some of these tumors are. So we do an excellent job, but still, when you're aiming for that 100% accuracy, whether with a biopsy or getting every single site of tumor, it still requires that kind of, you do the imaging, but it still requires a little extra on top of that. And the size issue is also a problem, because if we think about a lymph node, cancer spreads as just cells, right? I mean, when a cancer metastasizes or moves from where it started to other organs, which is the big problem, say it moves to lymph nodes that are right next to where it starts out at, that when they first get in there, they're just little cells. And so I can't tell that lymph node has cancer cells in it until it starts to grow to an abnormal size. And by then, it's a lot of cells have moved away from the primary tumor. And so you take that's one. So, I can look at a lymph node and say, oh, they all look okay, when there's actually a bunch of lymph nodes that are involved by metastatic disease when they do surgery. And it's just because the changes in size take a while to happen. I mean, cancer moves on a molecular level, but imaging kind of works on that more what we call macroscopic level, or in other words, I can't see cells on the CT scan. And it's just, now that's where PET imaging comes in, right? Because PET imaging then is set up to specifically bind to tumor cells. And so it gives us that extra level of sensitivity. So PET scanning or PET CT scanning in neuroendocrine tumors can find these lymph nodes that are not enlarged, but they do have tumor cells in them. So if we look at this example here, you can say, oh, okay, well, there's a metastasis in the liver, but we don't see anything else. And then you do the PET CT, and you see, yes, that there's definitely a metastasis in the liver, but what's that in the middle there? Oh, okay, and okay, that's a little lymph node that's right up against the bowel right there. And I just couldn't tell the difference between that lymph node and the bowel looking at the CT scan, but by the PET CT, it's obvious. And so lymph nodes are a huge advantage of PET CT. Bone lesions are also a huge advantage. So, studies have shown that CT scans can miss 80% or in that range of bone metastases, and PET CT is nearly 100% accurate for those in neuroendocrine tumors specifically, just because they're so subtle. Or sometimes it's not uncommon that a PET CT shows the bone mets, and I'm looking at the CT scan, and you can look at this PET, see exactly where it is. You look at the CT scan, you can't see anything, just because there's been no physical changes in the bone, even though there's tumor cells there. So it's still, the imaging is really amazing, but there's still limitations to what we can accomplish that requires other scans or other types of interventions on top of that. Oh, and then, timing of scans brought up. Why do we wait different time periods? And this gets so complicated that it's hard to even kind of sum it up. And part of that is that neuroendocrine tumors, there's so many different treatments that you can use. But one thing I will point out is that when you use radiation to kill a tumor, whether that's external beam radiation, where you lay on a table and the beams are, you know, introduced externally, kind of like a CT scanner, but with much higher doses, or if it's an interventional radiologist putting that catheter into an artery to put radioactive beads into the liver, it can take a very long time to see. The tumor may be dead from the radiation, but it can take a very long time to see changes in the tumor by imaging. So that can take a long time, you know, weeks or many weeks to see a change, even though it's successfully treated, or it may just be subtle changes, like changes in enhancement and not changes in size. And you know, there's a lot of variability in the time of the imaging, so much so that it's probably not useful to even try to discuss it, just to say that it's variable based on individual circumstances. Immunotherapy was brought up as well. But immunotherapy is even more complicated because sometimes immune cells just infiltrate the tumor and make it look a lot bigger. So if we do it, and this is a problem when immunotherapy was developed, we would do CT scans after therapy, like, oh, the cancer's worse everywhere, it's not working. When in reality, if you wait another couple months, the tumor goes away completely. And so what it is, it's like there's this activation of the immune system, and you can see new lymph nodes that are actually don't have any tumor in them at all. They're just infiltrated by these kind of immune cells going crazy with this stimulating therapy. And so for immunotherapy, it can take months, many CT scans to know definitively what's happening. So it can get very confusing. And there's going to be some, you know, with immunotherapy, there can definitely be some indeterminate, like, well, you know, everything looked a lot bigger. And we're assuming that that's an immune-mediated effect, but we don't know. We're going to have to wait till the next scan. So, and it can get that. This is where that kind of, you know, working with your doctor, taking the imaging in account with all the different parameters, your specific pathology, the specific therapies you've undergone, your other health problems, what specific therapy you've had, all that is going to, it can be very complicated to figure out the best imaging to get and the best time to get it. So there's just a lot of heterogeneity in that. And that's why kind of you come to an expert center, because, you know, a lot of these things are based on experience and less so hard and fast rules. That was it. That covers that list there. So
Thank you, Dr. Morse.
Yeah, absolutely.
Thank you. Yes, you went through the list that we proposed, and you really answered common questions that come about within our team and in clinic as we care for our patients. You made a very good point differentiating between the use of CT, MRI versus PET scan and how they answer different questions. And our colleague, Dr. Strasberg, is here as well. So in this last 30 seconds of the webinar, you know, we don't follow our patients with PET scan because we're looking to understand size changes and what I refer to as clinically significant change that warrants an escalation in care. So, John, can you speak briefly about when you find the addition of, let's focus on well-differentiated tumors, the addition of a PET dotatate, because we can have, you know, a year plus without pulling in that PET for our patients.
Sure. Thanks, and great talk. So PET scan for well-differentiated neuroendocrine tumors is good for telling us where the tumors are, but not so great at detecting changes in size, especially small changes in size. CTs or MRIs are better for that. PET scans can be useful if there's, first of all, a baseline staging, just so we know where to focus our future CT or MRI scans. Also, if there's clinical progression, meaning increase in symptoms but no change on CT or MRI, it might be useful to get a PET. Also, if the disease is in areas that, like the bone or peritoneum, where tumors are not very easily measured with CAT scan or MRI, a PET can be helpful. And then, of course, before PRRT, we need to do a dotatate PET to confirm that all the tumors express the metastatin receptors. So there are criteria for getting PET scans, and in some cases, they're more useful than others.
So in general, you know, the PET scan can answer some questions that cannot be seen or answered well on CT or MRI, but our, preference, and when we meet and put together guidelines, it's not to follow patients routinely with PET scans due to exposure risk and not really getting the measurements that we want to understand.
Correct. And of course, it's important to order the correct PET scan. So in the community, very often we see, instead of dotatate PET scans, patients get conventional FDG PET scans, which are generally not that useful for well-differentiated neuroendocrine tumors.
Well, I think I could spend another hour going over other questions that pop into my mind, but we'll stop here today. And Dr. Morse, thank you so much for your time and expertise. And we look forward to maybe bringing back a radiology talk in future webinars to answer different questions.
Great. Thank you so much. I appreciate the opportunity. Thank you for hosting me today.
All right. Have a good day, everyone. This webinar will be posted on our website and accessible at any time.